Hey, there you are. It's January 27, 2023, and this is the Room Now podcast. I'm Jack Cush with RoomNow.com. The podcast is brought to you by RoomNow.live. It's our best and upcoming meeting, March 18, March 19, in Dallas, Texas. Fly into DFW or watch it from home. This is a great meeting. I work all year at it. Artie Kavanaugh is the co-host. He's done tremendous things to make this a better meeting. People say this is unlike any other meeting they go to. Probably because the lectures are short, the discussions are plentiful, the break time is good. This is a fun meeting, and that's our objective. Great speakers, great education, great fun. A day and a half in Dallas or from home. I think you'll like it. The early bird registration ends, I think, at the end of this month, so you got a few more days if you want to get it on the cheap. So let's get into this week's abstracts and studies and news. You know, it's kind of like a week, meaning I can't see any blockbuster things happening this week. So I'm going to cherry pick here, and frankly, I'm going to be kind of snarky. So I'm going to change my name. My name is going to be Simon. My name is going to be Simon Brumatology. And that way, that's who you're going to blame for the things I'm about to say. And then at the end, we're going to take some calls from you, the viewer. Let's start with a study that I like, maybe. It's about dry synovitis. I don't know if you know about dry synovitis, but those in the pediatric rheumatology world do. When I was rotating as a fellow through the pediatric, and I did a lot of pediatric rheumatology with the rheumatology division led by Chester Fink and Lynn Pinero and Virginia Pasquale. You know, great people doing great things at the Texas Scottish Rite Hospital. Loved going there, loved learning. And Chet Fink was a masterful teacher, except he did this one thing that drove me crazy. He talked about dry synovitis. So Chet was a big guy. He would stand at arm's length from the kid, you know, with two fingers raking over the MCPs or PIPs, closing his eyes, you know, turning his head a little bit. With a little squint, he'd say, "I think there's dry synovitis here." And as a fellow, first and second year, I thought, I think he's nuts. How can you have synovitis and not feel it and call it synovitis? You know, so this is sort of, to me, a myth that exists. Either you have it or you don't. Well, here's a study that actually looks at this. I must say, it's a multi-center study to come up with 12 patients with dry synovitis. And the average age of onset here was 6 years. They all had polyarthritis, polyarthralgia, but no palpable swelling. They all developed progressive limitation of motion and contractures. That was sort of shocking, despite having normal SED rate, normal CRP, and being seronegative for RF and CCP. Imaging in these people did show bright signal indicative of synovitis and a tendency over time to develop osteochondral involvement. Again, this is probably a different, and they clearly say this is a different subset than polyarticular JIA, right? So what's different about it? Well, I just told you. And so my many years of doubting my mentor, Chester Fink, on this one issue probably, again, proves how good he was at what he was doing. I don't know that this exists in RA patients, but those of you who are doing lots and lots of ultrasound should be the ones to tell the rest of us whether it is so or not so. A sub-analysis of the Scleroderma lung study 2, which was a head-to-head trial, a comparative trial of mycophenolate or cyclophosphamide in patients with scleroderma-associated ILD. They did that we've talked about that many times. Many people feel this is a great study. Some people feel this is a flawed study in its design and then hence its conclusions. The good news is they got a lot of patients, and they did a sub-analysis that showed having patient-reported GI reflux of a moderate degree or higher was independently associated with change in their ILD and more fibrotic changes over a 2-year period. But none of this was associated with esophageal dilation or esophageal disease that they could otherwise identify. So these are patient-reported symptoms. Again, this is a study you probably shouldn't have done. So this falls under the don't do this. Why? A, it's a sub-analysis 4 years later, 8 years later, I think, on an original study that wasn't designed to look at this. Second, you're p-value fishing, and now you're resorting to what patients say. Again, everybody has ILD, and ILD progresses, so now you're looking for anything that was associated with that. Is that meaningful? I don't think so. So this is more about not the importance of reflux here. We know it's important. Does it predict lung disease? I don't think so. There's another study that kind of irks me. It's the PRED-SS study. And it's spelled like that, PRED-SS. It's a small trial of 35 patients, red flag, in early diffuse scleroderma, systemic sclerosis, and they treated 17 with prednisolone and 18 with placebo, and they looked at 3 months outcomes, and they showed that the results favored prednisone, but none of it was significant. So then what the heck are you talking about here? Why are you reporting this? They did say that there was less anxiety and less pain with prednisone. Again, you can't do large trials in early diffuse systemic sclerosis, right? So you get points for that, but the small numbers really limit you. The lack of a real control, they have a placebo control here, but again, I don't know what this really tells me. I'm not going to use steroids, and this study wouldn't even prove it if it did have p-values better. So that's the story here. Don't use steroids in scleroderma, and if you do, you have a risk of renal crisis, inducing renal crisis. But there are some patients early on, when the early edematous phase, before they really get bound down skin, that maybe giving high-dose steroids could be important in lessening that and lessening the ultimate amount of skin tightening. That's sort of folklore in rheumatology, backed up by some data. A study from India looked at 700 plus patients with lupus, and they were measuring plasma vitamin D levels, 25 hydroxy vitamin D, and they showed that the median values were roughly 23. And that low values, less than 20, were seen in over 40%, and correlated with age and geography. We know that to be true. Certain geographies in India are less well health-wise and are underserved. And age is clearly a risk factor with vitamin D, but showed weak negative correlations with the SLEDI2K. What are you saying here? Really? Vitamin D levels correlate with disease activity in lupus? That's been looked at many, many times. Vitamin D, very important in lupus outcomes. Your lupus patients should have their vitamin D levels checked and have it treated. But treating lupus with vitamin D, everything I've looked at says no, it doesn't really work. And it's like anything else with vitamin D. We all are, gun-ho about it, but show me a study where giving vitamin D gigantically changed the outcome. Now, recently I did hear Michelle Petrie talk about a study that actually did show some benefits, but I got to say there's a whole bunch that didn't show, so I'm still not a believer. Am I taking vitamin D? Yes. Am I measuring my vitamin Ds? No. So, yes, I'm a vitamin D curmudgeon, and I think that this was not a good study. Another study looked at what happens and why patients in Korea, 439 RA patients who are starting on a biologic or DMARD, why they made those choices. And specifically, they looked at those who were starting for the first time a JAK inhibitor, a TNF inhibitor, or a non-TNF biologic. And they showed that the choice of a JAK inhibitor was more likely associated with age, not having lung disease, having high disease activity, and prior tacrolimus. They use a lot of tacrolimus in Asia and Japan and Korea. We don't use so much of it here in the United States. And these are all significant correlations, but does this really help to inform your therapy? I don't know. Again, there's a lot of, JAKs are all the rage, and there's a lot of use of that out there. I don't think this helps inform who should be getting JAK inhibitors. We do know from a surveillance study that actually age is a risk factor for cardiovascular outcomes and cancer. And there's enough discussion about that we had in the past. So I wouldn't have done that study either. Don't do this, is what I'm saying. Do this. JAMA had a review of the treatment of TB, looking at the regimens, and I'm sure you probably know this. The old regimen of 6 or 9 months of INH for patients who have latent TB, LTBI, that's a positive TB test, but no signs of active disease, and a negative chest x-ray. And the reason we have to treat latent TB is that there's a 5 to 10% risk of getting active TB. That goes up as you get older. That goes up if you're on a TNF inhibitor. It doesn't necessarily go up on other biologics. Yeah, you can find me a few cases and some small numbers, but honestly, compared to TNF inhibitors, it's small. The risk is really here with TNF inhibitors for TB and non-tuberculous mycobacterial infections. Anyway, the treatment for LTBI, the preferred regimen is 4 months of oral rifampin. They show it's better than INH, it's safer than INH, you get it done quicker, it's very cost effective. The second preferred regimen that was actually, this was published in the New England Journal, is 3 months of INH and rifapentin given a few times during the week. This study also very well tolerated, a high percentage of completers, less serious adverse events, and of course associated with a lot of problems with completion and adverse events and lab abnormalities is daily INH for 6 months grade B evidence or 9 months grade A evidence. This week we reported on the Jackpot study. I don't know if you've heard us talk about Jackpot in the past. It's a 17 international registry analysis of patients who are going to cycle from one JAK to another or switch their JAK to another biologic DMARD. We've had a lot of messages from this Jackpot study, and they're not always the same. So this study has some limitations in my mind. Again, it's open label. It's what the doctor wanted to do, what the patient wanted to do, and what they did in that region versus your region. But the bottom line that they showed there was 365 patients who cycled amongst their JAKs and 1,600 who went from a JAK to a biologic DMARD. And the bottom line is, if you fail your first JAK, should you cycle or switch? They say cycle or swap. And the bottom line is that the cyclers and the switchers basically had the same outcomes. There was no difference, and it doesn't really matter. What they did show was that if you stopped your first JAK inhibitor for problems of adverse events and toxicities, that's more likely to happen the second time around. So it's a little bit like TNF switching, right, or cycling, or IL-6 cycling. It works. In my opinion, you can do 1 or 2, but not 9 of them, meaning you continually lose response. So this is sort of supportive evidence for those of you who want to keep on using a JAK or switch to JAK, especially if you're in a country where you have 4 JAKs available or 5 JAKs available. Such is not the case in the United States, where we have 3. Interesting report in, I think it was arthritis and rheumatism, on variable pregnancy outcomes with belimumab use in SLE. This reports on 319 belimumab exposed pregnancies with known outcomes. They drew their data from A, clinical trials, B, the belimumab pregnancy registry, BPR, and spontaneous reporting in the literature or to MedWatch. Overall, out of the 319, there were 223 live births. That's not really a great number. And they really report on 2 main outcomes: birth defects with belimumab and also on pregnancy loss. Birth defects were all over the map. Again, if you have no control population and you can't, it shows you the difficulty of doing pregnancy studies and looking at these numbers. We don't have a control. The population control on birth defects in the normal population is 3 to 6%, right? So in their study, they showed in the clinical trials it was 5.8%. In the post-marketing reports, it was 1.1%. Why the difference? Reporting bias? I don't know. But in the BPR, the belimumab pregnancy registry, it was 22%. What? And the question is, does that reflect who gets into that study? More about that study, BPR, in a second. When you look at pregnancy loss, it's also kind of a little bit all over the map, but the numbers are a little higher than what I would like to see. But in the RCTs, belimumab exposed was 32%, and the placebo exposed was 44% as far as the incidence of pregnancy loss, and that's all pregnancy loss, most of it being before week 20. The same was seen in the post-marketing reports where it was 31%. So again, this reflects the problems of this. But when you look at the pregnancy loss in the BPR, in the prospective cohort, it was only 2 out of 48 patients. And in those who looked at it retrospectively, as far as when they were enrolled in the BPR, it was 50%. So you go from 4% to 50%. This is a big problem. So there's another report that's out there in the Journal of Birth Defect. It's not journal, it's Birth Defect Research. This is actually a report that came out this last month also on this BPR, where they were supposed to enroll 500 plus patients to get the kind of data that they want. Turns out they stopped enrolling because they only had 55 patients. And the data that they got is kind of screwy, kind of worrisome. 2 pregnancy losses out of 53 pregnancies. And so that's kind of good. But 10 of the 53, or in another analysis, 10 of 45, had a major birth defect. So again, the recruitment didn't go well. Does this mean they only recruited patients who are going to have the most amount of problems, or who they already had problems? Again, this is one of the problems. Again, pregnancy research is incredibly difficult. The ACR 2020 reproductive guidelines on drug use say that rituximab, you can continue it, the drug, until you conceive, and then you should probably stop it because there's not enough known that you may continue it if severe life-threatening disease is present that you would be giving the rituximab for. But these data, again, are too all over the place to say with any confidence what to do. I have used belimumab during pregnancy because I'm a firm believer that the problem is the mother's inflammation and state more so than the drug that the mother takes when it comes to the fetal outcome. So I felt that, again, in this case, belimumab was needed to maintain a healthy pregnancy, and in fact, the mother delivers. So again, always be more concerned about the mother's disease activity than you are about what is known or unknown about the drugs. Let's go and look at or listen to a few questions from listeners. Here's Dr. Eve Scopolidis.
Hi, Jack. Eve Scopolidis from Ochsner Rheumatology in New Orleans here. I'd like your take on this fibromyalgia blood test that's been around for a few years. I think it's put out by the University of Illinois College of Medicine. I don't think I need it to diagnose my patients, but some of my patients insist on me getting it. What do you think about it?
Thank you, Dr. Scopolidis. Always a great question when you send one in. The test is called F/M/a test for fibromyalgia. I spent a half an hour researching this. No, I've never done it. No, I'm never going to do it now that I've read a little bit about it. This has been around since 2013 when it was presented at a national meeting. This test has seldom been published. It's a test that looks at chemokines and cytokines and supposed to actually help diagnose. Finally, there's a test for fibromyalgia. Do you really need a test to diagnose fibromyalgia? If you do, I would suggest quitting. I was going to say maybe redo the fellowship, but yeah, no, probably you should quit because this is a clinical diagnosis. You know, all of our diagnoses are clinical diagnosis. I don't need a lab test to diagnose anything. Yeah, you know, if I get a 60,000 CPK or 200 aldolase, yeah, it's going to be bad myositis and probably rhabdo. But then again, did I need the lab test, or would I have not gleaned that by looking at the presentation of the patient? So, A, this test costs over $1,000. B, there's no real peer-reviewed research, and it doesn't appear in any reputable journals. It doesn't have any, it doesn't have a pedigree of science behind it, is what I'll say. Patients are demanding it, and that's what Dr. Scopolidis is concerned about. What happens when your patient comes in and demands it? Well, the patient's kind of the boss. They want to do it. They want to pay for it, or they want their insurance to pay for it. Go right ahead. Am I going to use it? Nope. Now, I'm not a big believer in don't order tests unless I know what I'm going to do with the results. But if the patient's pushing, give them what they pay for. I'd rather satisfy the patient than try to have a toe-to-toe knockdown drag out on why I think this is the goofiest of all tests ever invented. Yeah, I think I just said that. Remember, my name is Simon Brumatology. Here's another question from Howard Van Gelder.
Hi, Dr. Cush. This is Dr. Van Gelder, practicing out in Southern California. I had a question about patients who have asymptomatic CK elevations with a large macro CK component. Do you typically work these patients up or follow them serially for autoimmune conversion, or how do you approach your management? Thanks.
Howard, I think I answered this again, but I couldn't find it anywhere. So I know you're sort of focusing on macro CK. I think its value here is incredibly limited. CK-emia does occur with JAK inhibitor use. In the rheumatology world, there's no cases reported of a patient, and these sometimes go into 200, 300, 400, maybe even higher. But there's no cases reported of actually frank myositis or muscle disease stemming from this. In the dermatology literature, I did find one case of rhabdo and not a lot of detail around that. So what do? I order a CK early on in using a JAK inhibitor, and then at 6 months. And if it's greater than 300, I might follow it, but I'm still not going to do anything about it until they get symptoms, and then I'll do an evaluation. If you want to do isotyping and macro CK, go ahead and knock yourself out. I don't think it makes you any smarter. Just as we said earlier, more tests doesn't necessarily help you in managing these patients. And right now, I think that this is the consensus opinion from all the JAK inhibitor mavens that I've been hanging out with in the last few years. Look at the safety data on all the JAK inhibitors at ACR, and the CK-emia issue comes up, but again, of no consequence. Our last question comes from Alan Epstein. Alan wrote me and said, I saw a 68-year-old physician who has psoriatic arthritis and is taking golimumab. He was diagnosed with melanoma in situ. Was there literature in the mid to late 2000s about recurrence of melanoma, especially in patients taking a TNF inhibitor? More recent data questions these findings, I believe. Again, he's asking for my opinion, and I often talk about this. I often have been confronted with this. I think that what you need to know is that, number one, RA patients get more of certain malignancies. They get more lung cancer. They get more non-Hodgkin's lymphoma, and they actually get more non-melanoma skin cancer. And there's always this little signal for melanoma, but it's rare, right? And all of that risk for those three cancers is related to RA and related to inflammation. Is it changed by therapy? Again, a lot's written, very little known, because the study designs are not very good. Specifically, this issue of melanoma came up when a number of years ago, the British Biologics Registry published a report in Arthritis Care and Research in 2010. They showed, when in their registry, the incidence of getting a cancer was actually higher on a DMARD than on a TNF inhibitor. And then they looked at patients who had prior cancer, and did they have recurrence of their prior cancer or on a TNF inhibitor or DMARD, and again, it was still lower on the TNF inhibitor. But what about if they had a prior melanoma? There were 17 cases with a prior melanoma who received a TNF inhibitor and an 18% recurrence, or 3 cases. There were 10 cases that had a prior melanoma who received DMARDs and there were no recurrence. This made people nervous. But again, it's a subset of a subset of a subset, and it's really low numbers, and there's obviously limited follow-up here. So two large studies. One looks at developing your first invasive melanoma. So again, Dr. Epstein's question is about melanoma in situ, which is the simplest, less than 1 millimeter epidermis only, no chance of recurrence, gets cut out with a big wedge resection, supposedly no chance of recurrence, or incredibly low. And yeah, I would use a TNF inhibitor in that situation. There's another study that comes in 2017 that looked at a few different registries. There were 11 registries in 9 countries, and looked at the risk of developing first invasive melanoma on a number of different biologics, including TNF inhibitors, and the answer was no, not increased, not at all. And then lastly, there's a Swedish national study that looked at 15,000 new TNF starts and compared that to 7,000 other biologics and 46,000 conventional DMARDs. And basically they showed the risk of first invasive solid or hematologic malignancy was really the same across the board with a number of different drugs, TNFs and non-TNFs. And first melanoma, same thing. So there was no increased risk of hematologic solid squamous cells or melanoma if you look at all those 3 different categories of therapies. So my answer to this question is I would use a TNF inhibitor in someone with melanoma in situ. Many of you would not. Hence, if confronted with a melanoma in situ, if you have other options, go right ahead. You're fine. But me, I'm going to use it because I'm not afraid of it. If it was a deeper lesion and indicative of invasive disease or malignant melanoma, change to another agent, because in fact this is still a point of contention between a lot of experts, and they're arguing based on really sort of skewed, poor data. So if you have other options, great. If you don't, then use the drug that works if you think it really works. Those are my takeaways. So anyway, I hope you enjoyed the podcast. Go to roomnow.live to register for our March 18 and 19 annual Room Now Live. Talk to you next week.